most times is mixed methods. A lot of research teams now are using both qualitative and quantitative to answer a more complex question.
Hello and welcome to the Dental Protection Podcast. My name is Noel Kavanagh and it's my great pleasure today to bring you a new series, Research in Dentistry. I was recently introduced to Terry Simpson, who's a dental legal consultant based in Leeds in the UK. Terry has been a general dental practitioner, GDP. He's been a practice owner in his home city of Edinburgh in Scotland. He's also been clinical effectiveness advisor for NHS Lothian and has led the Cochrane Systematic Review on treatment of periodontal disease for glycemic control in people with diabetes. Once I started talking to Terry, it certainly didn't take me long to realize that he has a really true passion for what research can do, not only for dentists, but I think for dentistry as a profession. So we did the only logical thing. We invited Terry along to be a host and to host a podcast series for you. So Terry, thank you so much for being here.
Oh, great to be here, Noel.
Tell me, Terry, can you maybe begin or start by giving us a quick overview of what you hope to cover for our listeners in this series? And I suppose answering that fundamental question to why is research so important in dentistry?
I'll be delighted to, Noel. The purpose of this series is to engage with dental professionals in all the countries in which dental protection has a presence. We're aiming to present an introduction to research and cater for dental professionals with no or little experience in this area. We will cover 4 topics in the series. The first podcast will explore research as it currently is in the world of dentistry. Our second podcast will focus on research in general dental practice. The third will concentrate on what to look for in reading a research paper. And our final podcast of the series will present an episode discussing the MPS Foundation.
Super. Well, that sounds great, Terry. And I'm especially looking forward to today's talk, actually. So, I'm just really pleased that you could do this for our listeners and members. So without further ado, Terry, I'm going to hand it over to your good self.
Thanks very much, Noel. So today's podcast is all about quality in research. When it comes to quality research in dentistry, there's enormous variability. It can be hard for dentists and other dental care professionals to know what to look for. Do all the papers we read have the same value? And how can we trust the results in papers? Without that ability to sift the good from the indifferent, it's harder for dentists to be informed and find the most effective therapies, including surgical intervention. Joining me today to talk about quality in dental research are 2 people that I've had the pleasure of working with before and presently, namely Professor Jan Clarkson and Dr. Josh Twigg. A very warm welcome to you both. Perhaps you could give the listeners an idea about your background and experience. Jan.
Thank you, Terry, and it's a pleasure to be part of this podcast series. So, I suppose I wanted to be a dentist when I was a teenager after orthodontic treatment, but failed to get the grades at A level, which was actually the best thing that I did. So I then did a physiology degree before doing dentistry. I suppose I'd been exposed to research, and so coming to the end of my dental degree, I knew research was something that I wanted to do. I then moved from Newcastle to Manchester, completed a PhD and specialist training in paediatric dentistry before taking up my current post in Scotland. And that was specifically to increase research in a primary care setting and to increase the implementation of evidence. So now I've been the principal investigator of 6 multi-million-pound funded NHS trials looking at routine treatments in primary care. I'm also the coordinating editor of Cochrane Oral Health and had the pleasure of working alongside you and Josh in that field because I recognise the important thing about research is for it to be used. And currently, I'm sort of like also I sort of like lead the Scottish Dental Clinical Effectiveness Programme and established the guidance that has been developed by SDCEP. And so really wanting to complete the circle of establishing high quality evidence, synthesizing it to exactly know what the results of world evidence say, but then translating that into knowledge tools in terms of guidelines that are used. And like you, I mean, it is a passion, and I thoroughly enjoy what I'm doing. And I think this venture for MPS is so important and valuable. So thank you, Terry.
Thanks, Jan. There's a few things I didn't know there, actually. Josh, over to you for a quick background.
Yeah, thanks, Terry, for inviting me to join you. So I graduated dentistry in 2013 in Cardiff. And then after a couple of years of foundation training and kind of dabbling in research, undertook a PhD in oral microbiology, which I then finished in 2018. Following that, I've worked in a combination of kind of NHS and private general practice alongside hospital roles. And now I've moved to Leeds and working as an academic clinical lecturer and a specialty registrar in restorative dentistry. And my main area of research interest is actually head and neck cancer and restorative rehabilitation of head and neck cancer patients.
Excellent. Thank you very much for that. Perhaps, Jan, you could start by telling us a bit about what type of research would be important for dentists.
I suppose, Terry, I mean, the important thing is it depends on the question as to what the appropriate research is. And whether it's quantitative or qualitative, there are quality standards. And so you want the highest quality method within whatever methodology is appropriate for the question to inform practice. My experience is mainly in the area of randomized controlled trial. And so there, sort of like a trial is the highest method to answer questions of interventions to improve health care and outcomes. And that's where my experience is. But equally, there are qualitative methods that could answer appropriate questions. I suppose to the part, quality standards for each study design that would be part of a critical appraisal tool. But I think what drives quality in research is actually working with the right people. You know, I work alongside the best methodologists to ensure that we do the highest quality research possible, whether that is in the primary care setting, or randomized controlled trials, or indeed systematic reviews and guidance development.
Thanks very much. Josh, you any thoughts on that?
Yeah, so as well as looking at the type of research in terms of trial design, I think there are some priority areas in terms of the research question and the topic that are important for practitioners. And when we asked this question, this was an exercise that was undertaken through the NIHR by the James Lind Alliance. So they looked at the top 10 kind of priorities for oral and dental health research, asking a combination of academics, practitioners, patients, really involving all of the stakeholders in that area. And most of the key areas that they identified were around prevention of disease, so prevention of caries, prevention of periodontitis, etc., early diagnosis of cancer, and improving access to care and communication with patients as well. So, there are known priorities within research, and these are often some of the more difficult areas to actually implement research in. I think the other thing that's really important is actually disseminating that research effectively to the people at the coalface, so that the GDPs and also to patients, to kind of empower them to use the findings of that research to change practice, because ultimately that's what it's all about. And I think that's something that Jan's work with SDSEP has really kind of forward, but it's still an area where we kind of haven't quite bridged that gap yet.
Great, thanks, Josh. So, Jan, where does most research take place, and how do we monitor that quality overall?
So I suppose, unlike medicine, in dental care is primarily provided within a primary care setting, and yet 95% of research is conducted within acute centres or secondary care academic settings. So where research needs to take place is where care is delivered. And as Josh mentioned, in terms of the priorities, prevention is the highest. And that obviously happens at the interface between patients and the healthcare providers. Now, actually, when we look at the evidence, we do know what prevents the bulk of dental disease, whether that's periodontal disease or caries. The issues that we don't understand is how to change behaviours. And so, in terms of what is the research that is required, very much in that setting, it is understanding behaviour change. So I think that, and certainly at the moment, the NHS is funding research in a primary care setting. There is huge challenges on delivering research in that setting, but that has to be the area. And for the priority areas that Josh has mentioned.
Great. Of course, we have to mention to some of our listeners, some have had no experience of conducting research, that research on patients has to pass through ethics committees. Does that ever present any sort of problems, Jan, for researchers, or is that pretty much, do people pay attention to that step in the process?
So any research on patients has to go through. And if you've not done it before, the advice would be to work alongside people who have and take advice.
Mm.
It is incredibly bureaucratic at the moment.
Mm-hmm.
Even for my teams, it is taking a huge amount of time, because not only do you go through the ethical approval, but you've then got to go through R&D. So that's research and development offices. And that gives a different stage of complexity, especially if you're working across different sort of like health boards or jurisdictions, even in the UK. So it is certainly something that is essential.
Mm-hmm.
And now publishers require confirmation that you sought ethical approval.
Yeah.
Some of our work, there's that grey area between service improvement and research. And even for that grey area, we do still ask for ethical approval, even if it's to get confirmation that it is not required. And that is what would go into a publication.
Excellent. That's great, Jan. Thanks very much for that. You did touch earlier on major types of research, I think, and qualitative and quantitative. Is it possible just to quickly give us a summary of what those are likely to involve?
I mean, I suppose what it involves is they're asking or answering different questions. So quantitative is actually calculating and measuring what happens. Qualitative, put simply, is around the why.
Mm.
And certainly, I mean, in terms of quantitative, you need data.
Mm.
And that is recording events and what happens. For qualitative, generally, there are two approaches. Whether you undertake, so it is having conversation, and it's often having structured conversations, and whether that is in a group, which will be called a focus group, or actually individuals, which would be an interview that could be done face to face, virtually like we are now, or indeed over the phone. But they are equally rigorous in terms of how they need to be planned and analysed. And essentially, they just give it a different quality of information. And most times is mixed methods. A lot of research teams now are using both qualitative and quantitative to answer a more complex question.
Okay, thanks very much, Jan. Josh, can you tell us, are certain publications taken to be more authoritative than others?
Yeah, so generally when you're talking about quality of evidence and the kind of authority behind what's being communicated, we look at this thing called the hierarchy of evidence. So this kind of pyramid of evidence with systematic reviews at the top, and then expert opinion at the bottom, and a variety of study designs in between. And that's not necessarily to say that you should always strive for that highest level of evidence. Each study design has its place, but the study designs towards the top end of that kind of pyramid or hierarchy of evidence have a lower risk of systematic bias because of their study design. So we typically look at interventional studies like randomized control trials to be top of the tree, with systematic reviews that summarize those trials above them, and then more observational designs that are less maybe applicable to the real world or have less control over different variables like case series and case reports to be lower on the hierarchy of evidence.
Okay, well, thanks very much, Josh, for that. Jan, could you just quickly, we talked about Cochrane very briefly. Can you just summarize what Cochrane's all about and what it offers for dentists and generally for healthcare professionals?
So Cochrane started, it's coming up to 30 years ago. And it is about an organization that is not-for-profit, international, and it's synthesizing the highest quality evidence around healthcare interventions. And so its focus has been in the past very much around randomized controlled trials, but increasingly non-randomized studies and qualitative work too is an area that Cochrane is involved in. And what Cochrane is asking is, in terms of the international literature, for any one question, what are the studies that are out there published in any language, in any country, that are addressing the same question? Once you pool all of the data from all these individual studies, that is going to give you the estimate of most certainty of the impact of an intervention. And it's got the tightest assurance. So it's sort of like limits the variation. And so for whether it's policymakers, clinicians, or patients, they can have assurance that Cochrane reviews are providing them with the most reliable, trusted, and best evidence to inform clinical decision making. And it has transformed really the presentation and provision of healthcare interventions around the world and impacted on guidance and guidelines across the world.
Thanks, Jan. Josh, what sort of study designs might we commonly see in dentistry?
Sure. So I think like most of healthcare, the kind of pinnacle of research in terms of changing practice is a trial, so a study of an intervention. We also see a lot of observational study designs, and they can be of a variety of methods. But there's a number of topics that are really important for dentistry, like water fluoridation, for example, where it's either not sort of possible logistically to deliver that as an intervention, or there's ethical concerns around doing it that way. And so, observational studies form the basis of your evidence base. I think we see less case reports and case series now across all of medicine because, they're seen as not particularly valuable to kind of driving changes in practice forwards.
And yet they're traditionally the most common type of study that's published, aren't they, I think?
Yeah, they're the easiest to produce. Essentially, you need one case or a few cases, but of course there's inherent biases within that. So how applicable that will be to a general population is certainly debatable.
Sorry, Josh, I'm just going to interrupt because it is really, really interesting when you look back at sort of like the role of case reports or case series. Actually, it was that research that highlighted the issues around HIV and AIDS. And it was the presentation, it was the case reports of hairy leukoplakia that really generated the move and the recognition of that disease. So they do, they have, as Josh says, they really have their place.
Right. I think probably it's worth just at this point talking about two concepts as well that we hear something about. One of them is internal validity and the other one is external validity. Would anybody like to sort of pick up on those two descriptions and give us an explanation of both?
I mean, I can start if you like, but internal validity is about, did it do what it was supposed to be doing in terms of a piece of research? And external is whether or not actually those results could be applicable to a wider population.
Great, that's very helpful. Josh, finally, would you like to just say a quick word on guidelines? Because obviously a lot of dentists don't have time to sort of do their own research, and some of them don't want to sort of wade through papers, and unfortunately they don't, as I say, they may not have the time. And guidelines are produced to help people in these circumstances, aren't they?
Yeah, so guidelines, serve a really important role of bridging that gap between the vast amount of information and research that's published on all areas of dentistry and actually applying that to clinical practice. And as you say, for a busy practitioner who's trying to balance multiple competing demands, it's not reasonable to expect them to kind of dissect the research, and that in itself is a skill. So it's very sensible that experts in the field can disseminate that appropriately. Generally speaking, guidelines are based on the best available evidence. But there's often areas in clinical practice where evidence is lacking or doesn't apply to an everyday situation. In those situations, it often comes down to expert opinion. That's a useful kind of facet for highlighting gaps in the knowledge and areas for future research, but it's not necessarily helpful to the practitioners immediately. The other thing with guidelines is they are often phrased in quite cautious language, and can avoid making definitive recommendations at time with this kind of deference to practitioners' clinical judgment. And I think people sometimes feel that, if they don't follow the guideline completely prescriptively, they'll be a bit hamstrung in terms of defending their actions. But of course, if you've got good clinical justification for what you're doing, then a guideline is just a guideline. It's not a rule. So it is okay to deviate from them.
You have to justify yourself effectively,
exactly,
don't you? Because they don't want to be in a straitjacket, really, for practitioners, really. Yeah.
But that's important in practice, regardless. You should always have clinical justification for what you're planning.
Right. Well, thank you very much. I'd like to give thanks to both of you actually for very informative contributions. With that, we reach the end of our first podcast in Research for Dentists series. If you'd like a certificate for listening, to go towards your CPD, or to learn more about what we've covered today and who you were listening to, please do look at the podcast description. I've been your host, Terry Simpson, and thank you for listening.